Hi there, everyone. Welcome back to another week of Intro to Ethics. I am so excited to be teaching this week because this, of course, is our unit on medical ethics. As I've mentioned, as you might have read in our course home, medical ethics is the field of ethics that I write, I publish most often in. It is the thing that I sort of see as my area of specialization. I will say as a note, I've made the deliberate decision to study with you this week 2 issues that I have not written or published about because I do not want you all to sort of feel as though you have to conform or think about my scholarship, think about things I believe, because this class is about you, forming your beliefs, making you a more critical thinker, making you a person who is thought more deeply about ethics and what is valuable in the world. And those things can't happen if you are too worried about what your professor thinks or if you're too worried about how I might retaliate against you for your opinions. Just because these are not things that I have published about doesn't mean I don't have opinions about them. So I'm still at risk of being biased. I'm aware of that. I'm going to work against my biases here, or I'm going to attempt to. And by that same manner, that doesn't also mean I am not educated or I've not studied or I've not done the coursework necessary to teach these topics just because they're not the topics of medical ethics that I am thinking about most often. These topics, and particularly the latter, which is euthanasia, are ones that I have had to do entire classes on. And so I am excited, I'm ready. I think we're going to have a great week, and I hope that you all enjoy medical ethics as much as I do. Medical ethics. Already, before I can even start talking about the topic with you, I have to give you some context. Medical ethics is sometimes called bioethics. Bioethics. If any of you ever go on to study philosophy in college, they're going to refer to this area of philosophy as bioethics. I talk about this in the course home, about an endonym and an exonym. Endonyms are words people inside a group use. Exonyms are words people outside a group use. That's all you need to know. People who write, people who publish, people who work in medical ethics call themselves bioethicists. People who are outside of philosophy, outside of the ethics world, usually call these people medical ethicists, or the thing they do, medical ethics. Why do bioethicists prefer bioethics? Part of it is because bioethics has medical ethics, yes, but also research ethics, clinical ethics, ethics of animals, so the philosophy of animals. Do animals have thoughts? Do they have emotions? Are we ethically justified to do animal experimentation? The philosophy of biology. So to what extent can we say we know anything in terms of biology? What are the ramifications of those things for us? So like, if the theory of evolution is true, does that have any sort of ethical implications for us? Like, that is all stuff that I had to study and that bioethicists do study. And it's just a sheer fact, the vast majority of us, if for no other reason, because of where the jobs are, end up working in medical ethics. There's also nursing ethics. So like I have written in what's called nursing ethics. When we look in this class at the Journal of Nursing Ethics, and in that journal, we're looking at nurses' perspectives about euthanasia. Often in hospitals too, hospitals have these things called ethics committees. So these are committees which, let's say we're trying to decide whether or not we should pull a plug for a patient, and there's all these different factors that maybe the family wants to get the perspective of a whole bunch of different people, or they want the perspective about what sort of ethical obligations we have. That is an example that we do ethics in hospitals through ethics committees. Sometimes we have ethics teams, which usually are legal. So these are people who, like I had to study the law and public policy of the state of Ohio around bioethics, around medical ethics. And so there's training to decide if a doctor doesn't know if they're breaking the law in doing something. This happens a lot right now with abortion cases. It happens with deciding to no longer give someone artificial interventions like artificial feeding, artificial nutrition, artificial hydration, that kind of stuff. If somebody is not what's called alert and oriented, their capacity to consent, we understand, is sort of stunted because they are no longer alert to reality or oriented to themselves or who they are and where they are. And so we imagine in the Ohioan and American context that there is suddenly a harder way of figuring out what it is they consent to. And we have all sorts of different ways of dealing with those things. Like, that's all super interesting. I know a lot of you have shared that you want to be in sonography, radiology, or nursing. Maybe some of you want to be doctors. Like, those are things that you're going to take in later classes that I think are so cool and I have a lot of opinions on. And that's all in the world of medicine. Most of you will not go on to get degrees in philosophy, get master's degrees in the field, right? And so these two terms are different. I think there is value to them being different. But I just want you to know both, because if you have an interest, you probably have an interest in knowing what these two different words are doing and how they're interacting with each other. So that's what bioethics means. In order to demonstrate, though, because it's going to be much easier, I'm going to have us return to just the term medical ethics. Because remember what I said, what we're doing here is applied ethics. And what does that mean? We're doing ethics. What are we applying to ethics? Medicine. So what is medical ethics? It is ethics in the world of medicine. We're applying ethics to medicine. That is what we're doing this week. Just as in business ethics, we were applying ethics to business. What does that mean? We're going to look at our good old question. Ethics is the process of what? Asking a question. What was that question? What should I do? Medical ethics is the question of asking, what should I do in medicine? Bioethics is the process of asking, what should I do in the biological sciences, or specifically in biomedicine? There are two topics that we study this week. This first lecture is going to look at the first part. Our next lecture will look at the next part. What was the thing that we studied this week? I'm going to say the thing we studied this week was something like the question, should clinicians ever lie? Should clinicians ever lie? There is this history I should provide before we get into it that I think makes the reading make sense, which is up until very recently in history, the way we as Americans saw doctors and nurses and clinicians as just anyone who is working in a clinical capacity. So your techs, CNAs, your nurses, your PTOT, physicians, PAs, MAs, anyone, LPNs, anyone working in a clinical context. The idea was these people had something that is clinical expertise, and then expertise in their discipline of medicine, nursing, ancillary support, physical therapy, whatever it may be. They had some expertise that they were giving you. So they were in charge, and they were providing a product that you needed. Some people still hold this philosophy, so don't sound like I'm putting it down. But it is no longer the dominant way we think about medicine in American society. We have postemptively looked at this period of time. That means, in retrospect, we now call this the age or the era of paternalism. What is paternalism? Remember, I mentioned that word last week when it came to sweatshops. Paternalism is this idea that almost as a parent does their child, individuals treat other adults as if they are children and make decisions on their behalf for them. So the idea was that doctors, because they understood what patients needed more than patients did, doctors would make decisions for patients. This was a belief that was just held. About the 1960s, people started to disagree with this. Think about the time, it's the Cold War era, and there is this incentive in society to embrace American ideas and to find what is distinctively American according to that cultural context, and to sort of emphasize it in all areas of public life. There's a lot of philosophers at this time, but to sort of paint the picture here, a lot of people thought democracy and autonomy and individual liberty belonged in all spaces, including in the doctor's office. So people started to believe that the point of medicine was not that these educated doctors gave something to their patients, but that good medicine was actually centered on the individual. If any of you are in nursing programs right now, this is something they're going to talk about. Specializing your care for your patient, understanding your patient as an individual. This is something that we've switched our attitudes on to a major point. During this time when we were trying to work out how this new turn away from paternalism looked like, there was this issue, which was sometimes those doctors were making those decisions because they thought the patient wouldn't be able to handle or wouldn't understand the weight of what it was they were telling them. Should clinicians ever lie? The real, sexy disease, if you will, that pushed this to its end was cancer. In the 20th century, cancer was very taboo. The normal practice when you got cancer is that you were not told you have cancer unless that cancer was easy to get rid of. Most people who got cancer died, and most of the time there was very little treatment available for them until later in the 20th century. The 20th century, by the way, are the 1900s. Most people believed you should not tell someone that they were dying because there was little that could be done. So when Cicely Bach, who's the author of one of our readings, who's also a philosopher, was writing, she was writing into a context of an American society that was starting to believe patients have these rights, patients have this autonomy, we need to respect patients. Patients are the center of our care. This major transition was happening. There was also a transition from clinicians being these really smart people who have something to offer to them being collaborators or people on your team as the patient, so to say, that you are working with in order to get to some goal you have for yourself. And doctors were sitting there and they had great intentions, and they were dealing with a society that didn't want always even to know that they had something like cancer, that it was baked into society, you don't tell people they have cancer, but also the sense that now they had ethical obligations to tell the truth. So this is the context that our first article is coming into. Bach is writing, I want to say this is the late 1980s, Lies to the Sick and Dying. And at this point in this transition, this is the debate. Deception, which is to lie, is either therapeutic meaning something like it is good for the patient or it provides them some good, which is obviously a goal of medicine, or a violation. The case study is that cancer example. I talked about cancer as being taboo. By this point, it's a little less taboo, but there was still little that could be done for a cancer patient in the 1980s. Compared to now, we're 40 years later, there's much, much more we can do for a patient with cancer than we could have done in the 1980s. But so Bach sort of imagines that she has a physician. So a physician is a doctor. And this physician knows that this patient is going to die of cancer. It is terminal. Terminal means going to die. This patient is going to die. And our physician in this example is trying to decide whether or not they're going to tell the patient they are going to die. What are some reasons Bach gives why lying or deceiving? She chooses deceiving here because if you've ever heard lying by omission, deception covers both telling someone a fib, which is a lie. So if I said you don't have cancer, but I might not have told you an outright lie. I might not have told you that you have cancer or you don't have cancer. But if I'm giving you false hope, that is a deception. If it is not clear that you know you have cancer and you're going to die, Bach uses deception because she's saying, look, that's lying. That is deceptive, so to say. And that action, if you think that's therapeutic, that's fine. That's one of the arguments Bach addresses. That's an argument people believe, and still today believe. At times, deception is therapeutic. So this physician is first saying, look, to deceive my patient might be therapeutic. Why? To avoid unnecessary pain or confusion. Pain and confusion are two different things, but we'll talk about both. Avoid unnecessary pain. If you were going to die today, would you want to know? Some people say yes, some people say no. Why do some people say no? If you knew you were going to die today, you could spend the whole day anxious about what it's going to be that's going to kill you. You know? Or in this case, you do things out of desperation because you are desperate to stay alive, right? It's also emotionally painful. Imagine telling someone they're going to die. You know, telling someone you have 3 months to live. That person is going to be devastated. It is going to be awful. And they only have 3 months left to live, and now you've made them spend a whole day of their life mourning. Something that I think our other author talks about that I'll mention here because it's relevant. You are going to be in pain. You have to tell someone if you're the doctor, and I'm not a doctor. But if you're imagining yourself to be the doctor here, you have to go through the painful experience of telling someone they're going to die. That's not exciting. That's quite hard. This other point, confusion. Sometimes people don't believe their prognosis. Prognosis is how long you have to live. That's different than a diagnosis. So they might believe the diagnosis you have terminal cancer or you have stage 4 cancer, but they might not believe the prognosis, which is that cancer will kill you in 3 months. There's this type of cancer called a glioblastoma, which you might have heard of, which is this really aggressive brain cancer that I see, or I used to see back when I was a tech working in neuro. Glioblastomas are awful, awful conditions. And if you were my friend and you came to me and told me you had a glioblastoma, I would say you need to spend every waking moment you have enjoying life. That's really dark. But Bach is bringing up a point here that if I deceive my patient into saying, I don't know what exactly you have, I just know you have very little time, or I suspect I won't be able to find a cure in time, they might give up on experimental treatments and do the thing you as the doctor want them to do, which is just enjoy what time they have left. They would have said, no rational person who knows what cancer or glioblastomas or lung cancer due to the body would ever seek these treatments. And maybe they would. This isn't a class about ethics and opinions. You're allowed to disagree with everyone. Me, doctors, anyone. Most doctors who dealt with cancer care in the 1980s had opinions like this about cancer. They would say quite outright, we see a lot of our patients who we tell the truth about their cancer to are confused about what cancer means. And so they made a decision to lie to their patients. Bach also talks about something else that I'll mention very quickly. There is this thing called the principles of biomedical ethics. If any of you ever read the Code of Ethics of the American Medical Association or the American Nursing Association, ANA and MA, they are both based on these principles that were coined by two philosophers named Beauchamp and Childress. And if you were to ask like a med student, because my master's program was in the College of Medicine, so I unfortunately know this to be a fact. If you asked a med student to spit off the principles of biomedical ethics, they would name these 4 things because these 4 things have been codified into codes of ethics for doctors and to a lesser extent nurses, because nurses I think just take less classes on ethics than doctors do. But I digress. These 4 things are the things that are supposedly determining ethical decisions from the perspective of a doctor or nurse. Not objectively, you don't have to agree with these, but these are the 4 things that are built into med school and nursing school instruction. Autonomy, which is something like the right of oneself to have control over their own decisions, their own body. Beneficence, which is good, doing good. Non-maleficence, which is do no harm. If any of you have ever heard the Hippocratic Oath, do no harm starts the Hippocratic Oath. Also, sometimes that's called non-malfeasance. And finally, justice. Bach makes a point. None of these say truthfulness. None of these say honesty. None of these say avoiding deception. They do say doing good and doing no harm. So she makes a point. People who believe this, and I want to make clear, Bach actually is on this side. I think she makes it clear eventually, but she's doing very good at representing this side, which you should do also if you ever are writing an argument paper. You should give due credit to the counter argument. But this side is saying, I am supposed to do what is good for my patients and avoid harming them. By lying, by deceiving, by not telling my patient the truth, if I think it will cause them unnecessary pain or confusion, I am doing something good. I am causing less harm. They're appealing to their training as physicians. Do no harm, the Hippocratic Oath. I will cause harm. My patient will go seek experimental treatments because they know what a glioblastoma is now and they know that they have it. Whereas if they didn't even know what that was, they couldn't have sought experimental research studies that are injecting random chemicals into them. That will cause them pain and confusion in the end of their life. They would have instead focused on doing what they could with the information they had that these people say they can use to coerce patients into enjoying their final days. Here's another one. Truthfulness is impossible. This is actually a really, really hard thing to deal with in medical ethics. That's really cool. I talked to you about a few types of cancer. I know what cancer is. It's something like cells have gone haywire. The normal mechanism they have to self-destruct is no longer working, and they continue to replicate until they build tumors that eventually cause harm to a patient. But let's say I have one person here, this one patient here, and this person has that glioblastoma, which is a brain cancer. If I wanted to tell the whole truth, I would have to, in perfect precision, tell them every blood vessel, every nerve, every cell in their brain, how they are impacted by this cancer. I'd have to tell them how many cells there are in this cancer. I'd have to tell them, what region of the brain is it in? What does this region do? Some of those are things we don't even know. I don't have to know down to the millimeter where your cancer tumor is in order to know it's dangerous. Your surgeon might need to know that. But you, in order to make a decision about whether or not you get a surgery for your brain cancer, don't need to know how many millimeters from your occipital lobe your brain cancer is, right? There's a thing we do when we ask for consent, which is you tell someone what you think they need to know in order to make a meaningful decision. But you don't tell them the whole truth because truthfulness is impossible. I actually don't know sometimes what the truth is. Let's say you were considering having this surgery that I was offering you for your brain cancer. I don't know what's going to happen. I can't tell you the truth. I don't know the truth. It's impossible. We don't know everything about every part of your body, about your cancer, and how they're interacting with each other. We just don't know every little thing. Down to the chemical level, I don't know everything. Down to the level of like quarks, I don't know everything. We just don't know everything about the world, the brain, the universe, matter. There are things we don't know. And so we make shortcuts because we think, well, you probably should know these things if you're going to make a meaningful decision. These people are just saying, I don't think one of the things you have to know is your diagnosis or your prognosis.